Hello, everyone. Welcome to the latest in our current series of virtual talks. It's my pleasure today to introduce our friend and colleague, Emilio Fernandez. Emilio is a consultant with CPFT and has been for many years and has been our lead from the Clozapine clinic for a lot of that time, but he's also an associate lecturer at the university department. Emilio has very kindly sent along a little abstract ahead of the talk, and you'll see that his research covers a very wide range of areas. But with particular relevance to this talk, I think there are two aspects of his work that I'd like to emphasize. And one is in dealing with what is often a chronic condition of schizophrenia. There is this very complex matter of how things evolve over time and the impact of chronicity when one thinks about the illness. And the second important factor is how exactly that evolution is modified by treatment in various ways. And with the individual patient, this is always very difficult to tell because we don't actually have the counterfactual. But Emilio's work has been with people in the clinic, collecting clinical data and research data on an ongoing basis. And what he's done in a lot of his work is try and look at the impact of how illnesses evolve, how different subgroups progress in different ways, and how treatment modifies or unmasks other aspects of the condition. And today he's going to talk about two particular areas here in treatment-resistant patients on clozapine treatment. Without further ado, I'll hand over to Emilio. Thank you very much, Emilio.
Thank you very much, Hisham. Thank you very much for everybody for being in today's talk. As mentioned, I'm the lead consultant for the Clozapine clinic for people with chronic schizophrenia. And schizophrenia is defined by the psychotic symptoms, but covers a wide range of other symptoms, the non-psychotic symptoms of schizophrenia, that range from the psychiatric symptoms, from negative symptoms, cognitive, motor, affective, or anxiety symptoms, to other symptoms are more related to the physical health or to the whole body disease, or the immunity and inflammation, as we know that there's a lot of work now, or the metabolic complications of the heart or the cardiovascular disease that are associated with the illness itself. My point is that as I work with chronic schizophrenia, my patients tend to have been treated with the only medication that we have, which is not for schizophrenia, is for psychosis. And sometimes this long-term antipsychotic medication might cause, worsen or unmask some of the other symptoms that makes very difficult from the clinical perspective to tear apart what is primary illness and what is a secondary symptom of the illness. And that's not a purely academic discussion. It's something very relevant for the daily care of the patient because you need to make some decisions based on that. Let me give you an example, the classical one. We know antipsychotics, especially the classical antipsychotics, they have this D2 antagonism that may cause those extrapyramidal symptoms, this Parkinsonism, and this hypomimia. And that's very common. It's something that we know. But hypomimia is also part of the blunted affect. It's part of the negative symptoms. It's part of the anhedonia or the depression that the patients might present. So this matrix, as Hisham was mentioning, about what is primary and what is secondary, becomes extremely important and relevant in the moment that you need to take care or treat the patient. I will not be discussing about negative symptoms today. It's another of the side interests, but today I will focus on these two main problems, which are the schizo-obsessive subtype and the antipsychotics causing diabetes. These two ideas that are always in the clinical practice, but we are not really good on tearing apart which part is because of the illness, which part is because of the medication. And also because they are quite relevant and quite frequent, are frequently seen in the clinical practice. I'm trying to have this model of not only having the clinical description, but I will present what we have tried to do for understanding the mechanism that might be underlying and what sort of interventions we have been designing in order to help patients. What do I mean by a schizo-obsessive subtype? Let me give you a clip.
takes about 25 minutes for me to get ready to go out to do anything at all. I do a series of checks. I start with 6 checks round, which involves checking. I start in the bathroom, check the bath, I check the taps, I check my medication in the cupboard. I then go to the kitchen, I check the cooker, I check the microwave oven, I check the taps again, I check the boiler. Then I check the bin in the sitting room, I check the ashtray. I do that 6 times around, and then I stop. Then I come back and I do 4 checks around. Exactly the same method, starting with the bathroom. I've been on Clozapine since about 97, 98, I think. But the OCD started coming in about 2001, 2002.
And that's extremely common. That's something that I work with people with chronic psychosis, and I see a lot of patients. I end up treating more OCD in my clinic than sometimes psychosis, because they tend to be chronic psychosis. And I spend more time working with the psychosis. And interestingly, if you look at the BNF, they suggest that the emergence or the onset of OCD after taking Clozapine is an extremely rare event. But that was not my clinical evidence or my clinical experience. Actually, there are quite a bit of work about how often these two problems, the obsessive compulsive symptoms and schizophrenia, are linked together, and that range from 5% of the OCD before psychosis to 15%, or if you extend the spectrum to the obsessive compulsive symptoms to 25%. And that has suggested this idea of having this schizo obsessive disorder as something different that is in between both disorders. So what I did is just starting to ask, 3-4 years ago, I started to ask my patients to complete a questionnaire about the obsessive or compulsive symptoms, very gentle. So it's a self-rated assessment, quite well known, the OCI. It takes 5 minutes to complete. They are waiting in the waiting room. They just complete this questionnaire. And we know that there are different thresholds to make the diagnosis or the suggestion of OCD. There are different thresholds, and we have been always using the more restrictive, so above 20 points at least. And the most interesting for me is that this scale also gives us the opportunity of having these 6 different factors or superscales: the washing, the obsessing, the ordering, the checking, the hoarding, and neutralizing. Basically about behaviors and obsessions about the patient. So gives this a broader picture about the patient, obsessive compulsive profile. A little break here, parenthesis. I do a bit of cheat. Along with George and with Gerhard, we managed 6-7 years ago to create a little tool that we use in clinical practice that helps me to create my clinical letters, but also to mirror all the clinical information into an Excel file, which is automatic, anonymized, in order to do all the clinical research I can do. This is ethically approved, and we have now quite a few cases. Just to give you an impression, that I've been looking after people on Clozapine since 2011, so I've managed to put a lot of this information that now database includes around 2,500 face-to-face intervention or contact with the patients and the follow-up of these patients. So allows quite a significant amount of information or data that we can understand. The first thing is, it caught me almost by surprise. About 50% of my patients score above 21 in the OCI, which is quite a significant amount. More than I expected, honestly, and as is mentioned there, very at odds with the BNF statements that people on Clozapine do not develop OCD, and it's a very rare side effect. I mean, I have half of my patients have very significant obsessive compulsive symptoms. That's quite a lot. But one thing is whether that has an impact. Whether that is very prevalent, but also has an impact. with Marjan, we published last year about how this group of people with very significant OCD symptoms have a much worse well-being state. So they perceive they have some difficulties in their well-being, and that might be associated with the OCD. What we are now exploring, and that's something we are now conducting, is whether the changes in OCD are also associated with changes in well-being, and that's the follow-up in 3 time points of these patients every year for 2 years, how the OCD, but also, of course, the psychotic symptoms and the depressive symptoms are correlated with the severity of the well-being symptoms. So it's not only something that is frequent, it's also something that is impacting the well-being of my patients. Then what we try to do is understanding a bit better what is the profile of the patient's symptoms. And that was very interesting for me, noticing that there were these 2 major categories. In one hand, we had the obsessive symptoms, so the intrusive thoughts, the parasite ideas that come to your mind and you cannot get rid of. And on the other hand, there were the checking behavior, this double checking, the need to reassurance. When they are in clinic, sometimes they will ask you 5 times before leaving the office, when is the next appointment coming, who will be contacting me? And this need of reassuring continuously. So these were the 2 symptoms, as you can see, is more around 50% of the patients will present these 2 symptoms. And what for me was more interesting was linking these 2 factors with 2 different risk factors. In one hand, the obsessions and the obsessing ideas were linked with the severity of psychosis. More psychotic symptoms, more intrusive ideas. And the other was about the checking. The checking was associated purely with the length of treatment. The longer is the treatment, the more chances that people might present excessive checking. That ranges from 30%, less than 30% for people with less than 5 years of Clozapine, to more than 20 years on Clozapine, and 60% of them developing significant checking behavior. So we have these 2 ideas forming there. So one of the models that I started to develop in my mind is that this idea of checking, that there might be a reason why people present this checking. And one idea perhaps is that this psychosis, understood as the hypervigilance as associated with psychosis, with the fear, that might lead to the obsessions and ultimately to the compulsion. So the need to double check continuously as a way of safety measure. That's a simplistic approach of what might be happening. But I give you another sketch, another patient who might explain that a bit better than me.
If you can tell me about the checking behavior, what do you do at home? So what is the routine that you check at home?
Before I leave the flat, I have to check things like the water's off, the taps aren't running, the boiler's off, the washing machine's not leaking because it has had a leak, and checking that all my stuff's there. But I can't check everything, so I have to sort of do it at random.
How much time do you spend checking?
About maybe 10-15 minutes a day, not too long.
And can you, if you're in a rush, can you leave the house earlier?
Yeah, I can.
Okay.
Yes, I can, yeah.
And is there any reason for you to check all these things at home?
Yeah, because people get into my flat.
Okay.
And I'm checking what they have. Because they do destroy things, make things,
So is that because some random people or a particular
people that live there? Okay. I know who does it.
Who is, flatmates, you mean? Or?
Not flatmates, but people that live above me.
Okay, yeah. So they get into your house,
yeah,
tap things, change things,
yeah,
and and you need to double check that things are
okay.
Yeah. Okay, thank you.
So this sketch, in this case, this compulsion is not really an OCD symptom as such. It's perhaps more a goal-directed thing. So he checks because he's concerned about the psychosis. But follow this logic of the psychosis, obsession, and compulsion. So one of the things that we did more recently, and that's still work in progress, is can we check that? Can we, sorry for using check all the time, but can we assess whether there is a link? And actually what we did is using the PANSS score, so the severity of the psychosis, actually impacts compulsion, but always through the obsession. That's a mediation analysis with this, I think it was 145 cases. And this idea that the two factors are having this, the impact of the psychosis is always indirect through the obsessions to the compulsions. So to summarize these initial parts, we have, the de novo obsessive compulsive symptoms are very prevalent. They have a deleterious impact on well-being, and they might be a byproduct of the psychosis, and with the psychosis effect on checking compulsion mediated through the obsessions. The point is how that might be happening. And I think that using other previous studies from another group in Holland, they found that actually the level of excessive checking is not only associated with clozapine, but also with olanzapine, compared to other people with the same length of treatment, but treated with other antipsychotics, such as misoprostol or aripiprazole. And again, as you can see, the profile is, again, purely checking. What is the difference between clozapine, olanzapine, and the others? The strong serotonin antagonism that they produce. And why is this relevant? Well, this is part of the work that we used to do with Julia Worf and Trevor Robbins and Valerie Boone, how the decrease of the antagonism over the serotonin receptors, especially the 2A and 2C, is associated with abnormal reversal learning, which is the key point for the cognitive inflexibility and leading to a lot of repetitive behavior. So that might be why people on these medications end up having more repetitive behavior. And I will not repeat here because I will not do as good as he does. All the work by Professor Trevor Robbins about the habit formation as the entry point for the obsessive compulsive disorder, and how the major role that serotonin and serotonin receptor might be playing on that. More recently, and that was last week, indeed, or 2 weeks ago, we have this paper. It's not from our team; it's from another team in Korea, that they have done just giving clozapine to rats, to mice, and actually over the weeks, the rats that have been treated with clozapine start to groom more this repetitive behavior, and that's seen not only in wild type, so normal mice, but also these mice that seems to have this genetic modification that are associated with OCD, and people with mice with clozapine develops more grooming. And more interestingly, if you treat with fluoxetine, which again enhance the serotonin function, this grooming is improved. So everything is pointed at the idea that perhaps the serotonin is playing the major role there. So my model, or my way of understanding this is, you might have two phases, where the initial phase, you have a checking that is a bit goal-directed action, where the compulsion is driven by the psychosis. But at that time, you are treated with clozapine. Clozapine might help potentially with the psychosis, but on the other hand, through the dopamine pathway perhaps, but the clozapine, what it does is enhancing all the compulsion behavior, leading to the obsessions and compulsion getting this circle between them and creating this OCD that is absolutely different to the psychotic symptoms. The point is, what can we do? Can we do anything? Once we have started to understand a bit what is the process, what can we do to treat these patients? And this is the last clip.
The last 5 years, I've been checking the door constantly, about 20 to 50 times. Checked if I see television's off, okay, and check my clock, see if my alarms are off, okay, check the front door, and I'll do every time before I go out, double check the taps, okay, in the bathroom all the time because I was scared of. I've never experienced as bad as that the last 5 years. Okay. 1997. Okay. Yeah. Okay, and before clozapine, were you also checking regularly things? No, I was fine in that department. How much clozapine were you taking 5 years ago? About 250. And the maximum dose that you have ever taken? About checking the door. I find it easier to lock and accept that it's locked. And I find that when I lock it, I get in the car and I would experience thought waves saying that door is open. I still get the thought waves, but the actual physical process is stopped. You know, I don't need to double check that door anymore. It's like I'm still thinking it, that the door's unlocked. But physically, you know, when I lock it, I accept it's locked. I still check the clock, see if the alarm's still on and things like that. I still double check the clocks.
I wish I could have the eloquence of my patients explaining the symptoms, but for me, that's very powerful message of how we can treat part of these symptoms. First of all, adjust the dose of clozapine. Perhaps some people might be taking a bit too much for too long, and adjusting the dose of clozapine is very relevant for treating that. There might be other options, other pharmacological options that I'm afraid I have not yet the data analyzed, but there's a lot of reports suggesting that adding aripiprazole or adding antidepressant might be helping to both the intrusive thoughts or the compulsions. But there's some pharmacological interventions. Another things that we have done is, what can we do when the pharmacological interventions are not enough? And along with James Plaistow and Helen Beckwith in Union House, I went to them 3-4 years ago. I mentioned this problem, and they set up very nicely some novel interventions, doing some CBT to our patients. We are still in the pilot phase. We have done 3 cohorts and no more than 14 patients. But by doing these interventions, we might be able to reduce some of the checking and the compulsions. But on the other hand, perhaps we are still creating more obsessions because people perhaps are becoming more aware of the symptoms. But there is some novel interventions that we can do. And James have created this leaflet that is raising the profile, asking more patients, and people are trying to find more ways to get some help and support. There are next steps. There are more things that we are doing. The most important for me is with Marjan. He's a PhD student, very talented, working with Trevor Robbins and also with Naomi Feinberg, trying to understand the cognitive profile of the patients with OCD, on clozapine with and without OCD, and comparing with patients with OCD and healthy volunteers. She explained me this slide a few times, but I'm unable to repeat them, but this is work in progress, and that's very interesting, along with the work that she will be starting to do with brain scanning, the 7 Teslas and the metabolites. That's one of the understanding a bit better the mechanism. Another is with Stella and other teams. Don't trust too much about the data there, because the numbers needs to be modified. But the idea that perhaps there are some genetic factors that are associated with both the transition from psychosis to obsessions and from obsessions to compulsions, and whether we can identify it before people start clozapine or olanzapine in order to prevent them to develop these symptoms. Yeah, the second part is about the other statements. Is antipsychotics cause diabetes, and that's something we have heard and we know quite regularly. Why is this important? What is the link between psychosis or schizophrenia and diabetes? What is this relevant? Well, that's linked strongly to the fact that people with schizophrenia have a 20% shortened lifespan. And that's mostly because of the cardiovascular disease. So the strokes, the heart attack that are associated with the metabolic syndrome, the problems that these people with the schizophrenia develop. There are few things that are very relevant here. One is that this gap of the excess of mortality has not been reduced over the last 20 years. It must have improved in people with bipolar disorder, but not in people with schizophrenia. The interventions to date are short-lived, are only effective as long as you're doing the intervention, and they tend to stop being effective after a few months of stopping the intervention. And for me, the more relevant of all of it is, and that was the work by Rudolph here, sometimes when you hear that people with schizophrenia die earlier, you might find, or you might think that that must be somewhere else, but it's not. This data by Rudolph were the mortality in people in our trust, people in Cambridge, Huntingdon, and Peterborough. And here, people still are dying 20 years earlier than the rest of the population, which is quite significant. One of the things I had in mind, or we started that 15 years ago, 20 years ago, when that was not very popular to say, could there be a schizophrenia per se associated with the metabolic complications? Could just the antipsychotic be purely unmasking these metabolic complications in people who are more vulnerable? So we did a lot of work back when I was in a previous life in Barcelona. We have a very nice NIH grant, and we studied in first episode psychosis, drug naive, what was happening, what was the link between diabetes and the psychosis. And well, we found that there were plenty of studies around, you can find around 15, 20 studies before the antipsychotic era. So we're talking about studies in 1920, 1930 that were associating diabetes with psychosis and schizophrenia. What we found is that among the patients in our cohort in Barcelona, there were more diabetes and pre-diabetes among the siblings or the parents of the people with the schizophrenia, people who were not presenting any psychosis, but there was some genetic component there that compared to healthy controls, people with the schizophrenia, their parents or their siblings, they were more affected with diabetes. So there might be some genetic component there. What we also found is that before medication in people with first episode psychosis, around 15% of the people might present some degree of glucose dysregulation. So not that much well-established diabetes, but the conditions called glucose intolerance or pre-diabetes. So something that is prone to develop diabetes. We also found that was not related to the common confounders about the healthy lifestyle or the diet. And we, to make the findings a bit stronger, what we found is that there were also molecular markers associated with metabolic complications, like the telomere length was shortened and reduced in people with first episode psychosis, drug naive before medication compared to healthy controls, to match healthy controls. But that was a description that we did 10, 15 years ago. A group of people with schizophrenia might be more vulnerable or might have this pre-diabetic condition before even antipsychotic. But we need to understand what is the mechanism, why that might be happening, and what is the relevance, and how can we use that clinically. Let me move you to the metabolic science. This is this concept of the 30 phenotype hypothesis that's purely in metabolic science, where this intrauterine stress, these problems during the intrauterine growth, especially malnutrition in the mother, might induce some changes in the growth, on the way that the intrauterine growth is done. So let me put that differently. The whole point is that if the fetus is getting the message that there is not going to be enough food outside, so for instance, because of maternal malnutrition or any problems with the placenta, they might rearrange epigenetically, might rearrange the way that they store energy to be even more efficient in order to store the energy. That's a survival mechanism, something that they need to do in order to, as they might face an environment without food. The problem is that when there's a mismatch between this early information and the information that you find when you are in a world hypercaloric, full of McDonald's and Wendy's, and what you have is actually a lot of caloric input. So therefore, you end up developing these metabolic complications. And that's a relatively well-established model in both humans and mice. There has been a lot of research on this. one of the surrogate markers of the intrauterine pool growth is actually the birth weight. Having a low, small birth weight is a marker of something bad, something happened during your intrauterine growth. And there has been a lot of studies about the development of diabetes in healthy population and the birth weight. And that's one of the latest meta-analyses, with a significant amount of population, with 7.6 million populations and 135 studies. And there's the link, very nice, between the development of diabetes. So, and in those who have low and very low birth weight, and also those with a high birth weight. Whereas people with normal birth weight between 3 and 4.5 kilos, so that's a normality, they don't have an excess of diabetes. Whereas these extreme, what we can call abnormal birth weight, they have an increased risk of developing diabetes. So that gives you up to a nice model, isn't it? Because we know that abnormal birth weight, that matches very well what we know about the neurodevelopmental hypothesis in schizophrenia. So we know that abnormal birth weight is linked to metabolic complications when they are facing an adverse environment. But also we know that those with abnormal birth weight they have an increased risk of developing schizophrenia later on. So one of the ideas was, well, that perhaps is a model that we can test whether those with abnormal birth weight are exposed to a triggering factor, which is not only the lifestyle, but the antipsychotics. And those might be those who will develop the metabolic complications. Why antipsychotics? That's a work, more recent work with Linda and with Peter, that actually, when you start antipsychotics, that change your diet. And there was particularly significant the change in the sugary drinks, so the colas, and how much colas people are taking after moving to a medication like Clozapine. And I have patients who drink 2, 3, 4 liters of Coca-Cola every day. But that gives you the triggering factor that might unmask the vulnerability. And that's what we were testing. So whether the vulnerability, which is the abnormal birth weight in people with schizophrenia, might have a trigger, which is antipsychotic exposure, and whether that might be linked to the weight gain that people might present. This idea that those with abnormal birth weight might have a greater weight gain. And that we first tested this idea with Hisham and with Clemente, with an all-time collaborator in Barcelona, checking our databases. And we checked, actually, birth weight was not correlated with body mass index in people, in healthy volunteers. It was not correlated with people with first episode psychosis, so with the potential risk factor, which is schizophrenia. But actually, there was an inverse correlation between body mass index and birth weight in people on Clozapine. So people who has been exposed to long-term antipsychotic medication, and those who were born smaller, they present a higher birth weight, a higher body mass index. That has been later, more recently, replicated also with our collaborators in Barcelona. That was a very small group of 23 cases that were started on olanzapine. So from first episode psychosis, 12 weeks follow-up on Clozapine, and the weight gain was associated with the weight gain, again, in a quadratic fashion. So those with the extreme birth weights were those who are putting more weight on. That was with a very small group of 12 weeks and 23 cases, and was later early this year, replicated with a Spanish network of research in first episode psychosis with almost 200 cases, with a longer follow-up of 2 years, and with people taking any antipsychotic. And again, the birth weight was predicting how much weight people was putting on. It's true that we have a different scenario here. It's mostly a linear, not a quadratic one. But again, there is something about the birth weight that might be associated with how the people put on weight once they are on antipsychotics. But I'm less interested on the idea of weight. I'm more interested on developing of conditions, and diabetes was an interesting condition. And I thought, for developing diabetes, you need time on medication, and that was ideal for testing this hypothesis of the thrifty phenotype in people on clozapine, because around 40% of my patients on clozapine, they have been taking clozapine for more than 20 years. So quite a significant amount of time. And that gives you this perfect model of vulnerability, trigger, long-term exposition, and the development of diabetes. And so we tested that in my database, and that was a work with Rudolph, with Hisham, and with Ryan Walker, which are a very talented medical student, and with Ed, about whether the birth weight was also associated with development of diabetes. First of all, we just checked what is the prevalence of diabetes among the different people with the different birth weight. And you can see this curve again. People were born with a very low birth weight or low birth weight or high birth weight. They have higher prevalence of diabetes compared to the others. And even more, if you do that was a Kaplan-Meier, differentiation between those with a normal birth weight and not a normal birth weight, and that was confirmed using other techniques, but that's a bit more graphic and more interesting. Those who have this abnormal birth weight, they have more likelihood of developing diabetes and early diabetes compared to those with no abnormal birth weight. But still, you can see that around 50% of the people with normal birth weight will also develop diabetes. That might be other reasons, such as, for instance, family history of diabetes. And we can see that family history of diabetes is also a very strong predictor of developing diabetes. That's in people on clozapine. So, sorry, that's a graph from the time that people start on clozapine and 25 years of follow-up on clozapine. And at the time they have been diagnosed initially with diabetes. As you can see, people with family history of diabetes, they tend to present more cases of diabetes and early onset of diabetes. And to make things a bit more beauty or more robust, let's say, actually you can combine both risk factors. And people without any of these risk factors, 25% develop diabetes after 25 years. But people who have either extreme birth weight or family history of diabetes, it's almost 70, 80% of them will develop diabetes after 25 years. And if you have both of them, it's a very strong predictor that you will develop diabetes within 10, 15 years of starting clozapine. So that's quite powerful indeed. It's something that you can gather when you are doing the clinical practice. You can ask people about their birth weight. You can ask about the family history. And that gives you a profile of people who might be developing diabetes. That's a long-term project as well, that you can do some mouse models on that. We have a very nice mouse model of not giving enough caloric intake to the rats, and the newborns will develop some kind of cognitive problems that resemble some of the process that we, or the working memory deficit that we see with people with schizophrenia. That's a long shot, but this is a long-term project that might also validate this model of linking this abnormal intrauterine growth with diabetes and schizophrenia. The problem is, well, once we have associated, we have seen that perhaps there are both family history and abnormal birth weight increase the risk of diabetes. What can we do? And there's something that can be done. That's a work with Jorge and with Golam and with Peter again about a meta-analysis about how the intervention of adding metformin before the diabetes is established might reduce the body mass index, the waist, and also the fasting glucose. So perhaps now that we are understanding that there are people with a higher risk, what I am promoting at the clinic, but I cannot do that extensively as yet, is promoting to the GPs. I have this patient who is on clozapine, is taking these two, has these two risk factors. Can we prescribe metformin? And that helps to reduce weight and to prevent and to delay, at least for sure, the development of diabetes. Please, that's a completely different thing. I'm not suggesting that everything that is related to diabetes is because of the birth weight. the antipsychotics have a direct impact, and for sure that this 25% that still present that this says something there. And diabetes and metabolic complications in people with schizophrenia is very complex. And Julia was a very talented anthropologist from Australia who spent a couple of 18 months working with us and in Australia and having some interviews about the well-being in our patients, and completely different approach to the one I tend to do. And it was very interesting. And the kind of different ideas that we need to remember that sugary drinks, for instance, or food, and even smoking, are one of the few pleasures that people with schizophrenia might have. They might struggle to find a job, a partner, friends. The limited amount of possibilities to have some pleasure and enjoyment might, some of them, be food. And that's something that they might be reluctantly give away just for the long term of living a longer life, when, you know, right now I might need to enjoy this time. Before, that's not really related to the topic, but that's a paper that we have published this week, and it's very important and very relevant. At the end of the day, what we try to do is to reduce the mortality in people with schizophrenia. And that's a work well done with Changquan and with Emily and with pharmacy department and Rudolf, seeing at all deaths associated with clozapine in people in our trust. And we have a total of 33 deaths, which is more or less what is expected among all the in different studies, so mortality around 0.5, 0.8% of all the patients. But what we found, and nobody has done that before, is actually dividing the deaths in 3 different categories. So something that is expected, someone has cancer and has nothing to do with clozapine, something that is suicide, and that might be something different. But what we found is that 50% of the deaths were unexpected. People that we were not predicting that they will die, and we arrived to the clinic and all of a sudden they were found dead, and we didn't know why. And there were 2 or 3 factors there. One, the fact that most of them were taking a very high dose of clozapine. And they were smokers, but they were especially very high dose of clozapine. And we have not been checking enough the plasma levels. The other thing is this peak in 2018 of unexpected deaths that was associated with a heat wave. And that's very relevant. The fact that most of our patients perhaps are not drinking enough water during the heat wave, the plasma levels go up, and all the side effects associated with the plasma levels might be triggering a lot of mortality in our patients. And we have something to do. And with Concha from the pharmacy department, we have been working on with Chris Jenkins about changing the way that we do the routine monitoring of the plasma levels. The plasma levels right now is something that we don't do. That is not nice recommended, but we are changing from now how we do the guidelines, and from now on, every year in April time, we do the plasma levels in order to prevent, if there will be a heat wave, just to adjust the plasma levels in order to prevent these excessive deaths. And all the other problems that we know that people present huge variations over time without no particular reason. So it's good to check the plasma levels in order to prevent the deaths. I'm finishing. What I'm talking about up to a point helps or reminds me about the heterogeneous that this disease is. Schizophrenia, for me personally, is not a disorder, it's probably a syndrome with more symptoms. And whether we can start to use the findings or the things I express after taking medication in order to make some subtypes and go back and to understand that perhaps those with more neurodevelopmental markers, abnormal breath weight, for instance, might need another type of medication or might have a different root of the illness that might need a different interventions. And that might be very relevant, I think, for the future. That's part of the project. That's a bit of publicity, sorry. That's the Clozapine Clinic research program, let's say. We have been discussing today about the obsessive compulsive symptoms and the physical health, but we have many other projects exciting about the negative symptoms and collaborations with many other people. And And some exciting is coming up now with John Sacklin and some art-related work, and with Kate Tierman with the Tate Gallery as well, doing some very interesting work. But yeah, let me conclude. The OCD is commonly seen in people with Clozapine, and is probably associated with the strong anti-serotonergic activity, but it's treatable. Diabetes onset is after Clozapine might be in part associated with the family history and intra-uteral factors, and the low birth weight. And there are some preventive strategies that are available. Antipsychotics might unmask the patient's vulnerability to both OCD and diabetes. And that might help to, if we go back, to personalize the treatments and the schizophrenia subtypes in a different way that not only symptoms-based. And my big motto, research-oriented clinical activity is not only feasible, it should be even mandatory at the NHS. That provides a better clinical care, and we should be improving and using more this model. And let me finish by giving thanks to everybody there, which is intentionally in alphabetical order, because everybody is as important for conducting the clinical and the research activity at the clinic. Thank you very much.
Thank you very much, Emilio. Thank you all. Emilio, we have a few questions in the chat, starting with Leith.
Yeah. This distinction between obsessions and delusions, and that might be rational versus irrational. To be honest, again, I think that all these distinctions are very nice and very clear when the patient is 18 years old and they come to the clinic for the first time. But after 25 years on medication, people have gone through so many processes, phases of learning, not learning. It's not only about the obsessive symptoms, it's also about hallucinations. They understand that the hallucinations are part of the illness, but also believe on the hallucinations. So things have become much more muddled and much more complicated. The patients might distinguish, and perhaps you have noticed in the video that all these patients have gone through clear-cut paranoid delusions that being persecuted. And these ideas for them are different. They come as irrational. They don't like the idea. They can these parasite ideas, but they come continuously into them. Hope it helps. Shall I move to the next one?
Leith, if you'd like to follow up.
No, that's perfect. Thank you. Thanks for answering my question.
Okay.
I know you've got a couple of others. We can come to them in order.
Okay. One is from Ulrich. Thank you, Emilio. What happens when patients stop Clozapine? Yeah. Do the OCD symptoms get better? Actually, there's an improvement of OCD. I have a lovely case that I couldn't record, but lovely case. Someone who was on Clozapine for a number of years and developed such a massive OCD symptoms. Once she was waiting for the bus, put one foot in the bus, but then couldn't decide whether she wanted to put the second foot or not. And that was a Friday afternoon in Regent Street, 5 p.m. And it took 1 hour and a half for her to decide whether to go inside that bus or not. Can you imagine the chaos that created? She ended up later on, and she was on Clozapine for 10, 15 years and developed this massive OCD. And she actually ended up being so unwell that ended up in hospital. We changed antipsychotic to haloperidol for another reason, and actually the OCD is not present anymore. So yeah, that might be just this unmask that is happening. The problem is that we need to be careful how much Clozapine you can reduce and whether it's a good idea to change the antipsychotic just because the presence of OCD. It's a bit complicated. There's another from Leith. Do you think that the effect of Clozapine is directly metabolic, or does it affect impulsivity? I love these questions. I love this one. I don't know. I think there is something there. I think that the compulsivity that you see in patients after taking Clozapine might be something also related to these symptoms. Again, that tells you about the complex matrix of things there. I think that there's a lot of more work to do. I don't think that they are two completely distinguishable side effects. I think that, as you said, I think the compulsivity associated with, or the rigidity that clozapine does might also influence how difficult it is to change habits, to move to healthy habits to patients on clozapine. And that might also link to an excess of more obsessive, or worsening the physical health. Okay. Marija, thank you very much. The evidence showed that 3/4 of people with long-term also abnormal birth weight and family history. Call for more. Oh yeah. I think that we should be. The problem with that is we are not that many people, or this is a study that perhaps has not been widely replicated and needs more widely replicated. But of course, that is not only about adding metformin. That should add even before reaching clozapine. Perhaps if it's someone with the first episode of psychosis and with these risk factors to develop diabetes, perhaps instead of using olanzapine, might be helpful using other agents in this population, in this particular group. But of course, that you need to do many other things, the physical exercise and other work. Glenda, who is also in this picture, and Fabian and everybody at the Clozapine Clinic has been trained as a health advisor as well, in order to help and to change some of the behavior. And we have now a dietitian that comes once every Tuesday to help, or used to come, not before the pandemic, and helping people to change their behavior. But it's not easy. It's very complicated. More questions from Leith. Yeah, the ethnic origins. That's a good point. I haven't checked the ethnic background of my patients. They tend to be honest, 90% are white British, so it's 70-something% or 80%. But I haven't added this information into the database, basically because I forgot to put that when I designed the database, so I cannot extract that easily, so I cannot put that. But I'm sure that also playing a role there. Thank you, Luisa, because the police were called for the bus stop. That used to be your patient, it's true. Okay, and okay. How efficient?
One last question from Millie.
Yeah, how efficient is to add aripiprazole? I think it's very, very much, but to be honest, if something I have learned over the years is not trusting anymore my instincts or my impressions, what I see in clinic. What I need is to check the data, because I always find some surprises. But putting that aside, if we go back to the obsessive compulsive symptoms, if we put the two types of the two phases, with the initial phase more linked to psychosis and the second phase more linked to the serotonergic action, perhaps one of the options is people who are still very psychotic and start to develop some checking, perhaps adding aripiprazole. That will be the ideal scenario, because you are treating both the obsessive compulsive symptoms, but also treating the hallucinations and the psychosis. And that's a very effective treatment, the combination of clozapine and aripiprazole. For those who are already doing not psychotic, but just purely presenting the obsessive compulsive symptoms, perhaps it's time to reduce a bit the dose of clozapine. And if it's not working enough, adding the SSRI in order to control the intrusive thoughts and the compulsions.
Okay, I think I think that we've probably come to the end of the questions. So can I just draw us to a close and thank Emilio for a fascinating talk, and also just to illustrate the power of doing clinical research that is actually embedded in the clinic to inform, one, our understanding of these conditions, but also how we treat people. So thank you very much, Emilio, for giving us your time and discussing your work with us. And thank you all for attending. Have a good rest of the day.
Thank you very much. Bye-bye. Bye-bye.